come to collect you for your surgery, is that okay?
Right.
In the UK, some 3 million major operations are carried out every year.
Nice big deep breath. We'll look after you, don't worry.
Only the country's top surgeons are skilled enough to take on the most critical cases.
Cameron, you all right?
Just take a couple of deep breaths.
If you're going to make a hole in someone, you better be sure what you're going to do.
Should we go for it? Right.
They're using pioneering techniques to treat conditions that used to kill.
A few years ago, these operations were felt to be too big or too dangerous.
But pushing the boundaries of modern medicine comes with great risk.
Just keep quiet for a second, please.
If we move the blade too much, she's going to wake up unable to breathe.
Life is precious. It can vanish in a heartbeat.
Whoa!
You need to keep your head.
Hold this. The heart is empty. We haven't got any volume at the top.
If you panic, the patient can bleed to death.
The surgeons bear the ultimate responsibility.
I need it ASAP. I can't wait for this.
I'm not infallible. Failure is absolutely possible.
We are a team, but there's one person's name at the top of the bed.
Bloody hell.
This is what really happens behind the closed doors of their operating theatres.
This is a battle, us versus the Grim Reaper. And we're not going to lose.
People, they say, oh, that must be terribly awful dealing with children. And, well, I guess, yeah, it is stressful.
In the heart of the city, Birmingham Children's Hospital is a world-leading centre for complex paediatric surgery. Around 70 life-changing operations are performed here every day, many on children who are still just toddlers.
To breach the body is a big deal, isn't it? Any surgeon doing any operation feels that sense of responsibility. But when you're operating on children, there is that added factor which ups the ante.
David Barron is one of Britain's top paediatric heart surgeons, specialising in conditions that develop before birth.
Compared to what we felt was the limit at the turn of the century, things have changed. We're able to do things that we didn't appreciate might be possible. We're always striving to be better, and we always want to be better than everybody else. That's in our nature.
David is about to perform open-heart surgery on 3-year-old Madison, who has been in and out of hospital since she was born.
Once you get to know her, she's the life and soul of the party. She just doesn't give in to anything. She just wants to keep going.
She is very confident. Not scared of much.
Madison has a very complicated type of heart condition that's called pulmonary atresia, and that really means there's no connection between the heart and the lungs in the normal way that there should be. There are many varieties of pulmonary atresia, but this particular type is really rare.
Before blood is pumped around the body, it has to be oxygenated. Normally it's carried directly from the heart to the lungs, where this happens, via the pulmonary arteries. But in Madison's case, those arteries never formed correctly and do not connect to her heart. This means blood can't get from her heart to her lungs as it should. To compensate, Madison's body relies on several narrow vessels called mapkas, which branch off from the body's main artery, the aorta. They act as a makeshift route for at least some blood to reach her lungs. We all have these vessels in the womb, but by birth they've usually become redundant. Madison wouldn't be alive without them.
Shall do it, Mum? I don't think I can do this, Mum.
But the amount of blood they send to her lungs is far less than normal, so her blood oxygen levels are low, and that has slowed down her growth, leaving her much smaller than a 3-year-old with normal circulation.
She's only in 1.5 to 2 year clothes, and she's 3. Seen her not very well. It's hard, because she's such a good girl.
For her parents, mechanic Phil and catering assistant Michelle, it's a miracle that Madison was born at all.
It was detected on a 20-week scan. The doctor said that she was not a viable baby, and he says on paper she shouldn't be here.
It's a bit high.
Madison needs an operation to correct her circulation by building a new route between her heart and lungs. The procedure is risky, but without surgery, her body will continue to be starved of oxygen, and she's unlikely to survive beyond childhood.
Just trying to hold it together. But it just, yeah, keep it in and keep going.
Okay, we've got everybody. Oh, that's better. So we have a bed, we're good to go. And so it's just one case today because she'll be an all-day case. She's only about 10 kilos, isn't she? Quite small. She's 3 years old, so she's small. So left side up first, just to mobilise the vessels, and then turn her on her back, find everything we can, join it all together. So plenty to do. Very good. Let's get cracking.
He said there was 10% chance of her not making it through the surgery. Love you. See you later.
Take a sit there, we'll
I don't want to see her going to sleep. It's in case she doesn't wake up again.
That's all I can do. Make her understand that she's safe, and it might hurt for a bit, but it'll make her better.
Okay. You're doing really well, Madison.
Consultant anaesthetist Vasco Lagina Rolo is responsible for Madison's life support throughout the procedure.
Now, Daddy will stay here with you, and you are going to have a nice sleep, aren't you?
I think it is beyond any comprehension. As a parent, your main responsibility is to protect your child from all harm. And in that particular circumstance, you're actually not. Someone is actually going to cause harm to your child in order to make them better.
Get you to give Madison a nice big kiss. See you later. This will take good care of Madison for you.
Yeah. That's incredibly hard for a parent to accept.
The procedure to correct Madison's circulation is so challenging that Birmingham Children's Hospital is one of the few places in the world equipped to tackle it.
A-protein got started, yeah?
Yes, A-protein tester started.
Yeah.
First, the team will prepare Madison's MAPCA vessels by separating them from the surrounding tissue. One by one, the MAPCAs can then be disconnected from the aorta and then combined with the malformed pulmonary arteries, bringing together all the vessels that can carry blood to her lungs. In order to link these combined vessels to Madison's heart, the team will use a synthetic tube, giving her normal circulation for the first time in her life. Stage 1 of the operation involves going in through Madison's side to give David the best possible access to the MAPCA vessels.
So a knife, please. Knife to skin is that moment where everything focuses. It is a sense of sort of nervousness and anticipation. That moment is usually actually a tremendous feeling of release. The fact we're getting on with the operation.
We need to be all over the place today, so I want to try and get a good view for this. We've got a lot to achieve. Let's have the chest retractor, please, Lindsay. That's great, yes. And then we'll try and find the vessels.
Madison's condition is extremely rare, and the procedure to correct it is far from routine.
I'm not sure what that is.
You're finding yourself within parts of the chest that you're not used to operating within, really.
I'm not sure whether that's the map that I'm looking at here, trying to work out what's what, really.
Certainly at times you can lose your orientation, and it's important then to take a breath and just readdress everything.
There is one more vessel that comes off the opposite side of the aorta.
To the right lung.
So, yeah, but I'm not sure how easy it's going to be to find. It's a small vessel.
Working in the confined space between the heart and lungs, David relies on his optical magnifiers to help him tease out the MAPCA vessels. These tiny tubes are just a couple of millimeters wide, but each one could play a big role in supplying blood to Madison's lungs.
Just make some space.
The more vessels you have, the better. The general rule is try and find everything you possibly can, because you can't have too much.
So just a silk.
David identifies 5 MAPCAs that he wants to use, and he marks each one with a silk thread so they can be found again later in the operation.
I think I can just sort of dangle them in there. It should be easy enough to find. Okay, so I think we're finished. So I'm coming out, let's go.
The vessels and the silk threads are tucked back inside, and the incision is closed. The team can then reposition Madison for the next phase of the procedure, opening her chest and rerouting the MAPCA vessels to create a new connection between her heart and lungs.
So ready, steady, move. Great.
Even in the spectrum of children that we see with her type of condition, she's got a much more difficult set of blood vessels to deal with than normal. And when you're doing these sort of rather fiddly operations with lots and lots of things having to be sewn together and reconstructed, this carries a risk that we have to be open and frank about, that not all children can survive this sort of surgery.
At Birmingham Children's Hospital, they also deal with another kind of life-threatening condition that develops before birth.
Okay.
Consultant urology surgeon Liam McCarthy is a specialist in disorders that affect the kidneys and bladder.
Hi Emma, everything been okay overnight? No fevers? Excellent.
His challenge today is to try and transplant an adult donor kidney into a 2-year-old boy called Isaac.
He's got an obstruction of the tube leading from his bladder, and this has caused back pressure on his kidneys. So the kidneys never develops normally.
His parents, Lee and Amy, became aware of the problem during a routine pregnancy scan.
Not lady.
Not the ladies.
I was maybe 18 weeks. And they'd done the original ultrasound and they just said, look, there's something wrong.
Shoes off.
Obviously, I was crying my eyes out. They weren't sure whether he'd actually be, they used the term viable for life. At 37 weeks, he was born by a C-section and whisked off to the neonatal unit.
Where's those tubies?
I say, wakey, wakey, tubies.
Good morning, tubies. Are they going to be good tubies today?
We knew from day one that Isaac was going to need a transplant, just because even on the ultrasounds they could see how much damage had already been done to his kidneys.
Isaac's kidneys don't effectively filter the waste from his blood.
You're normally so good.
To correct that, he now has dialysis 3 times a week.
All his chemical imbalances that he has, they make him sick. He gets really tired. He can't go to soft plays, he can't go to the park, so we're having to restrict so much that he can do.
That's it. Now what's missing? So where's the tummy going to go?
Dialysis is keeping him alive, but in the long run, the costs are high.
Dialysis has long-term complications, so life expectancy can be reduced between 40 and 60 years. That's a huge chunk out of your 80 years. If you have a new kidney, you get a very large chunk of this back. So you get much more life, and you get much better quality life.
Poppy, Isaac.
Yeah.
So Isaac's parents have agreed to a transplant.
Bum.
Under your bum. Careful, because your lines seem a bit shorter today for some reason.
No.
During the operation, Isaac's damaged kidneys will not be removed, as doing so would cause unnecessary trauma. But the adult donor kidney is far bigger, and the challenge for the team will be to find room for it within the abdomen. They hope to position it behind the bowel and connect it to the blood supply in a completely new position, much lower down on Isaac's major artery and vein. The final step will then be to link the new kidney to Isaac's bladder.
It's a major surgery where we're going to be putting an adult organ into a small child. So he's at the limit of what we can do in terms of transplantation. But he's also approaching the point where if we don't, then dialysis is going to become an issue. So getting on and doing it, if we've got the opportunity, is the right thing to do.
What about nighttime kisses from Mummy and Daddy?
Yeah.
Yeah. Thank you.
The kidney Isaac needs is being donated by his father, delivery driver Lee.
Good hands. Good boy. It is a strange feeling knowing that my kidney's going to be in Isaac, but he's half of me anyway, I suppose, isn't he? So finding out that I was a match was a relief more than anything. It never crossed my mind to have second thoughts. As soon as the option was there that you can do something for him.
I couldn't be prouder of him. He's not once just been like, I don't want to do this. It was just like, no, I'll do it.
Isaac, can you give Daddy a big love? And a big kiss. Thank you. We'll see you tomorrow. With the surgeries, I'm a lot more confident and laid back about mine than his.
Mummy.
With Isaac, it's quite a big operation for him. A lot more risks.
No.
I have profound respect for families that go through this. It is a hugely brave thing for Lee to do.
Lee's healthy kidney will be removed 5 miles away at the Queen Elizabeth Hospital. He's prepped for surgery in Theatre 14.
1, 2, 3. I see that. Starting. 9:51.
The team begins by making a small keyhole incision in his side.
Lights off, please.
Navigating by camera, they locate Lee's kidney and remove the fat that's built up around it before clamping the blood vessels and disconnecting them. The kidney is removed through the same small incision. Another surgeon flushes the blood out, and the donor organ is packed on ice.
Can we send straight away?
Specimen is going.
Outside the body, the kidney will begin to degrade. Keeping it cool will help, but to prevent serious damage, the transplant needs to be made as soon as possible.
You waiting for my kidney?
I am, bless you.
The kidney is rushed across town by an emergency response driver.
Have you walked all that way?
You doing?
Big cuddle from Mummy.
You're gonna have crutches.
At the Children's Hospital, Isaac is given a general anaesthetic.
Oh, thank you. I'll see you later. Thank you.
Door closing.
I need to readjust everything, so
Yeah,
we're
yeah.
leaving it on.
Should be fine.
Yeah, great.
Okay.
1, 2, 3.
In theatre, Liam and his team make their final preparations for surgery.
My body is tiny, isn't it?
Dad was quite big, Isaac was quite little, so the amount of space for us to operate is restricted.
Liam, how big is the kidney?
Good 12 centimetres. We're going to need the kidney shoehorn to get this in.
Because of the risks involved in this kind of surgery, Liam will be joined in theatre by a colleague, consultant transplant surgeon Khalid Sharif.
The margin of error is very small. So for these smaller kids, for example, the transplant ones, we have decided 2 of us will do it. And that is just to have a safety factor.
Khalid, we're likely to put a patch on.
Uh-huh.
Hey, let's come down a bit. When you're dealing with people who are tiny and we're doing big things to them, having 2 sets of eyes and a mutual respect makes the whole thing a safer, more resilient process. Neil, ready for me again? But complications do occur. There is a risk of things not going right. Roughly speaking, in the UK, about 1 in 100 people who have a renal transplant do not survive the procedure.
In the cardiac theatre, 3-year-old Madison's heart operation is approaching a critical stage.
You good to go, Vasco, from your point of view? Yeah.
Whenever you want to.
David Barron and his team have identified the MAPCA vessels that they need to create a new connection between Madison's heart and lungs. Next, they have to detach the MAPCAs from her aorta before bringing them down towards Madison's malformed pulmonary artery so they can all be combined together.
Okay, knife, please, when you're ready.
Knife?
To reach the vessels, the team must now carefully expose Madison's heart.
Opening the breastbone is a very emotive thing to do. It takes you inside the chest of the child.
Madison has had heart surgery before, and they'll open her chest in the same place.
Okay, lovely. It's had a wire cutter.
It's one of the riskiest steps of the entire operation.
Going back in is potentially a very hazardous thing to do because you have to be very careful that we don't damage the heart with the saw as we go in.
Just try and go in as carefully as we can.
It is something which is an anxiety-provoking moment in the operation.
Saw, please.
If the electric saw penetrates the outer surface of her heart, Madison could suddenly lose a dangerous amount of blood.
Okay, Vasco, we're going to open up.
That is potentially a risk of a catastrophic bleed you can very rapidly lose your entire circulating volume. You need a degree of resilience within your personality.
Scissors now, please.
You have to have self-confidence or self-belief because the risks are pretty high.
So we've got the heart off the back of the sternum.
Now they've safely opened the chest without tearing the tissues beneath. Madison's heart is finally exposed.
I'm absolutely fascinated by it. It's an extraordinary thing. We cannot design anything close with the best technology to work as efficiently or as beautifully as the heart does. So it's fascinating being able to then intervene when the heart hasn't quite formed properly and looking at the ways you can try and correct things back as close to normal.
It's quite a big volume-loaded heart, isn't it? I think it'll be nice to get on bypass.
To work on the vessels around the heart, the team must take the pressure off the heart itself by placing Madison on bypass using a heart-lung machine.
We'll go on to the heart-lung machine now. Clamped there.
The machine will pump Madison's blood around her body and provide it with oxygen.
Yeah, just open it. There we go. Okay. So that cannulas in the aorta. You okay, Vasco, yeah?
Yeah, all normal now, David.
With Madison on bypass, anaesthetist Vasco can monitor and manage her circulation right through this long and complex operation.
I see myself as a well-being guardian during surgery. David Barron is one of the few surgeons in the world that does this kind of surgery. You need to really be at the top of your game to be able to provide him with the best possible surgical conditions.
So let's just pull up on all of these.
With Madison stabilised, David begins to look for the MAPCA vessels that he marked earlier. The black silk thread he attached to each one makes them easier to spot. Carefully working around the heart, he disconnects each vessel where it meets the aorta.
Okay, scissors please.
Once they've been detached from the aorta, David can pull the MAPCAs down towards Madison's pulmonary artery. He'll cut along the length of that artery and open it out before stitching the MAPCAs onto it so that all the vessels leading to her lungs are brought together.
Here's the napkin. I could just join it in as a double join, I suppose.
The surgery we do in this sort of condition is one of the more kind of extreme things that can be done within children's cardiac surgery.
This will be the most awkward bit of sewing I've got to do, I hope.
You're working down a rather narrow space and you've got limited movement.
Where has it gone? Lost it.
And on top of that, you may have blood and fluids constantly getting in your field. We used to get taught as junior surgeons to pass a needle through a set jelly in the bottom of a flower pot and to try and do that without the needle tearing through the jelly. And that's quite a good way of imagining how to do things. Your anxiety is what's going to happen if it all falls apart.
transplant theatre, the team are getting ready to give 2-year-old Isaac a new kidney, which has just been removed from his dad, Lee.
Having them both in surgery on the same day, it's awful. I can't be in two places at once. I want to try and be there for them both, but it's very stressful.
Okay, knife please.
You haven't attached anything yet.
Okay, so have we got an easy clean tip as well?
Yeah.
Okay, we'll need it in a moment. Yeah.
With Lee's kidney sitting on ice, surgeons Liam McCarthy and Khalid Sharif prepare Isaac for the new organ.
A lot of fat.
A lot more fat you'd expect for someone with chronic renal failure. There we go.
Yeah.
See where we are.
To get to where they want to position the donor kidney, the team have to carefully pull aside Isaac's bowel.
So, can we have the retractors, please? You want to put it on your side or this side?
That side's pretty easiest.
There is stuff which is there, and you just have to lift it out of the way.
Okay.
But it's like everything in a small child. They don't have a huge physiological reserve, so you've got to do it without making a huge amount of hemorrhage happen.
You need to have a right angle ready.
Because it will be positioned lower down in Isaac's body, the donor organ can't be connected to his blood supply in the same place as his own kidneys. Instead, it'll be plumbed into his body's major artery and vein in an entirely new position.
Shall we divide this ligate?
The next step is to locate the artery and vein and expose these vessels enough to make a good connection.
Yes, that is one of the vessels we are interested in.
The risks are all to do with finding the right vessels, not damaging things you don't want to damage.
There's nothing attached to it, no?
And it's gonadal vessels.
If we've had long-term dialysis, actually the vessels can be quite affected and they can be quite stuck.
Just mobilise this bit here so we've got a bit more space. Get rid of this. It's going to be a nuisance otherwise.
And if they're stuck, it can be difficult to mobilise them and things can bleed.
Swab, please.
Big swab, yeah.
Right.
We'll need the kidney in a minute to see where it fits, okay?
With the vessels prepared, the team need to work out how the new kidney is going to fit into Isaac's body.
Okay, so we've got the kidney. Let's have a look at it. Wheel it over here.
In somebody of Isaac's age group, that's the size which not many people do the transplant in UK or in the world basically. So we have a space.
If your kidney doesn't fit, that's clearly a big risk.
It's going to be tight fit.
Yeah. Okay, Liam, put it in.
Okay.
Non-tooth forceps.
The vein's going to go down there. The artery's going to go there.
Forceps, please.
A 2-year-old's kidneys are about 6 centimetres long, but the donor kidney is twice that length and 8 times the volume.
Yeah. It needs to go in here.
Before they attempt to connect it, they need to be satisfied that it will fit and that all the vessels will join up.
So you have to have a rotation of at least 10 degrees when you are putting it in. So put it there.
So I think we just put the vessels basically side by side pretty much.
Yeah.
It's a very simple thing. It's how are we going to arrange this organ so that the two pipes I need to join together are going to be able to reach the point where we're going to attach them in the child.
That's the renal vein.
And the renal artery, it is going to sit on top.
Okay.
I think that's going to go there very nicely.
Yeah, perfect, yeah.
Okay, I'm happy with that one.
The kidney itself will gradually degrade as it warms up. So there's a certain amount of time in which to do this.
Put it back. Okay, the clamps.
With the kidney back on ice to preserve it as long as possible, the team must quickly make their final preparations for the transplant.
It's a point where really there's no going back and you just got to get on with it.
Outside the cardiac theatre, Phil and Michelle face a long wait for news about their daughter, 3-year-old Madison. She's now been in surgery for 4 hours.
Obviously, we're going on what they say. They've worked this plan out. He knows what he's doing, and we trust everything will be fine. We just have faith.
Okay, there you go, George. Just need that one, I think.
In theatre, cardiac surgeon David Barron is carefully constructing a new link between Madison's heart and lungs.
Okay, good. So I've got everything. Quick suck inside there. Have I got enough length?
He's detached the MAPCA vessels from her aorta and brought them down to her malformed pulmonary artery. Opening that artery up, he has stitched the MAPCAs on at each side, combining all the vessels that link with her lungs. Before connecting all of this to her heart, a patch must be added to seal the joins. It's made from a special kind of donor tissue called homograft.
Needles there.
Yeah. We've tried to use as much of her own tissue as possible, but that's not enough, and you need to find something else.
Let's have a look and see. We want to use the best quality bit that we've got.
We want to use something that's soft and flexible, so it will naturally adopt to the curves and the twists and the little angles that we're sewing that material into without it creasing up, and something that won't degenerate over time.
Okay, we're going to go down. So just grab the other end of it. I'm not sure where that put it. Is that it? No? I think it's over here. Yeah, that looks about right.
A homograft is a tissue graft donated by another person and tucked away just 1 floor below the operating theatres. Birmingham Children's Hospital has its own dedicated tissue bank. This is where the patches are prepared, using tissue carefully salvaged from donor hearts. Each year, the technicians receive as many as 90 hearts, from which they can produce up to 200 patches. When they arrive, the hearts are dissected in a cold storage room under the same sterile conditions as an operating theatre.
All our donors come from within the Midlands region. From the time of death, we've got approximately 48 hours. You know, the condition will start degrading over time, so the vast majority of our tissue is processed and in antibiotics within 6 to 8 hours.
The heart is cleaned and the fat is removed before it's dissected to retrieve a usable patch of tissue.
There's not many of us technicians that do this in the country, probably 2 dozen maximum. It's 6 months of training on pig hearts and then human hearts from then onwards. I'm coming up to 19 years of being here, and I've processed 750 to 800 donors in that time. I'm a bit apprehensive of every heart because you are aware that you could make mistakes, I could damage the tissue and come out with nothing. It's me and that heart. You've got a donor family that are relying on you to, you know, they've made this amazing donation that you have to do the best you can to fulfil their wishes.
Once the homograft material has been prepared, it's stored in a concentrated antibiotic solution for 24 hours and then placed into cryopreservation at up to 190 degrees below zero.
The most rewarding part for me is I can go home every day knowing that I've played no small part in saving or at least enhancing a child's life. It's really nice to go home with that feeling.
There's the patch coming through.
The homograft patch is carefully stitched into place to complete the reconstruction of Madison's vessels.
Needles coming.
For us, it's a very beautiful piece of material to work with and to do our reconstruction with.
So we have finished the patching. I've got a long way to go still.
Yeah. The homograft patch creates a perfect seal over the vessels. And onto it, David will now stitch a synthetic tube, which will become the link to Madison's heart.
So this is the corrugated tube.
The tube is the final element of the reconstructed blood supply for Madison's lungs. But before it can be connected to her heart, the team has one last issue to overcome. Madison's condition has also left her with a hole inside her heart. Only when it is closed will her body be able to circulate blood normally for the first time in her life.
Okay, so that's everything, yeah?
And in order to work safely on the heart itself, it must now be stopped altogether.
Cross clamp, please.
In her case, that's an extra added risk that we know the heart muscle isn't quite as healthy as we would have expected. And so to put her through a long and complex operation where there's going to be a period where the heart is stopped is an additional risk to her on top.
If you hold that up in the air, George, okay?
An extremely cold chemical solution called cardioplegia is pumped through the heart, which stops it beating and protects the tissue.
Half flow.
Half flow.
Clamp is on, thank you. Run your pleager and come back up.
Back up. Pleager's running.
The heart stopped. Pump sucker, please. The knife, please. 15 blade, yeah.
With the heart no longer beating, David can cut directly into its outer wall.
So let's just have a look, make sure I can see my way around there.
Going in through the new incision, he uses an artificial patch to fix the hole inside Madison's heart.
Okay, that's the big patch closing off the hole. So we've finished it there.
With that done, David can now stitch the synthetic tube to her heart, completing the new link to the lungs.
So we're now just connecting to the heart. I'm just going to come one more stitch and I'm going to stop. Okay. Whew.
Madison's heart has now been stopped for an hour. With the reconstruction complete, the team must now restart it and hope that the new vessels function as planned.
So, clamps off.
Lungs off.
Come back up. Yeah, lungs off, thank you. The heart will now hopefully start to wake up. Right, good.
Once her heart is pumping blood unassisted, the team can finally separate Madison from the heart-lung machine.
So you're back on full flow, yeah?
Yeah, rewarming, yeah.
It's an absolutely key moment in the surgery when we come off the heart-lung machine, when you really need the whole team completely focused on what we're doing and to be aware of all the things that might go wrong. Madison's case, it's quite a lot of surgery and a lot of suture lines, so you certainly are anxious and worried that you're going to have a problem with bleeding at the end of these sort of operations.
some bleeding is expected. But if David's stitching is sound, then it should soon dry up.
He's got a bit of bleeding. Suckers on, please. If the bleeding carries on more than you anticipate, then it's an anxious time. More swabs, please. Just 1,000 things that can bleed at this stage. So just look at the echo again, Rob. So that's stopping. That was all weeping before, wasn't it? It stopped. It's always a great relief when you see the circulation balanced the way you want it. So we're gradually getting there.
Madison now has a new pulmonary artery, carrying blood from her heart to her lungs. And with the bleeding stopped, David's work is finally done.
Oh, don't tell me you're tired. Come on.
This sort of procedure, which where you're standing at the table for 12 hours, is about the limit of certainly what I would want to do.
Don't be a wuss.
It's physically and mentally exhausting. A soft tissue patch. And I think I'm going to go for a lie down. There you go. Yeah, okay, thanks guys. Oh.
You take the pipes, can't I?
Yeah, you can. Thanks, Rob. I was very happy that we'd managed to really find and recruit all the vessels and probably get the best result I could have hoped for. But the sort of technical achievement of the surgery is only part of the story. You're only really happy when you know that the heart and the circulation and the patient behind it is recovered as well as you'd expect them to.
In the transplant theatre, 2-year-old Isaac's surgery has reached the final phase as the team prepare to connect the donor kidney.
So what we need is the venotomy knife, the ring tip and the straight blue handle. Okay.
Working together, surgeons Liam McCarthy and Khalid Sharif must now stitch the new kidney's vessels into Isaac's blood supply. And they need to work fast.
Okay, kidney please.
Okay, so we've got plenty of cold flush available. It's probably one of the more pressured things I do because the clock is on. As soon as the kidney's actually on the edge of the patient, there is a finite time in which to get the joint done.
Nice. Perfect.
There we go. You've got a kidney which is progressively being damaged by not having any blood in it. You want to be less than about 45 minutes, but ideally quicker. Please have some lubrication to my fingers, please.
Liam asks for his hands to be lubricated to make sure he doesn't snag the stitches at this crucial stage.
You've got 2 tubes and you've got to join them together. Okay, you want to hold the end of that? And you've got to do it in such a way that you don't provide a rough inner surface, which might promote clot formation, and which doesn't leak. Okay, that's good.
The first connection is to the major vein that will drain the kidney of blood.
I think it's going to be okay.
I think I'll put one more just to please me.
Anything to keep you happy, Carlos.
Beautiful.
That's good. Okay, cold on the kidney.
We're clamping the aorta now, Neil.
Should we just lift up?
Then the kidney is stitched to the major artery that will supply blood directly from the heart.
So I'm just going to come in about there. That's it, that's good. I like that.
You've done so nicely. Beautiful, Mr. McCarthy.
Okay, so we're taking clamp off the aorta.
In theory, Isaac's blood should now begin to flow into his new kidney for the first time.
Right, so let's take this off.
Yeah.
Okay, so arterial clamps off. Kidney's lovely and pink. It's filling beautifully. Okay, and venous clamp is off. So nice and pink, that's what we want to see. You've done the best job you can to put everything together. But you take the clamps off and it turns pink, and it's a huge relief. Okay, let's just prepare the ureter.
The final stage of the operation is to connect the new kidney to Isaac's bladder so that the urine it produces can be removed from the body.
Okay, hold that, hold it.
Forceps, please.
Nice and firm.
Before making this connection, the team must be happy that the kidney is functioning as it should.
Having seen the kidney turn pink, what you need to know is that actually it's going to be able to produce urine. That's what the ultimate test of a kidney is. And we've got urine. It means the kidney's actually working. Okay, hold that.
With urine flowing, the team can connect the kidney to the bladder.
Looks beautiful.
Then finally, they can replace the bowel and carefully close up Isaac's abdomen.
So I have to say, I'm well impressed by this. Okay. It's actually posed quite nicely, isn't it? Yeah, it went pretty well. That's better. There's profound relief when it's all working.
Hi, I'm with Isaac Willocks.
While he recovers, Isaac will be taken to intensive care for further monitoring.
I knew I wanted to do surgery of some sort, but when I first did paediatric surgery, I felt a fraud because I did not have any children of my own.
Hey, Squishy. You did good.
At the end of that rotation, I got married and my wife and I had our first kid. I then got the chance to do paediatric surgery again and it felt much more natural. Being a parent gave me a lot more insight into what it was like to actually look after another human being. I think it makes me a better surgeon.
That's the koala. That one's a lemur.
Lemur. What lemur?
It's a bit like a monkey. A little bit like a monkey.
2 weeks after the transplant, Isaac and his dad Lee are both recovering well from surgery.
I'm feeling okay. Still can't do anything strenuous, but everything's going pretty well. It's nice to have everything sort of getting back to normal. Nice to have Isaac back. Leave it in.
The recovery was really, really quick. So just so glad it's over now. And we can start looking forward to not having to worry so much.
I just need to keep an eye on him. Provided he doesn't get unlucky, provided we do our job well, then actually the kidney itself has got a 10 to 15 year average lifespan. Of course, in and amongst that, there will be kidneys that go on much longer.
When Lee's donor kidney eventually stops working, Isaac will need another transplant. His mum Amy is also a match, but it's too soon to know whether her kidney would be the best option.
Get one, doggies. When you look after a child, you're looking after a family. There is a huge amount of emotion and trust that's required. And it is a huge thing for a family to hand their child over to someone to do this. But while the kids get sick quickly, but they also get well quickly. And that's a very nice thing.
Yeah.
No more. No more.
After a month recuperating in hospital, Madison is finally well enough to be discharged.
You have to have it on before you go outside.
Daddy,
Yeah?
do I need to take that one?
Yes. Your bandage?
Yeah.
Madison has a real will to survive. This is the best shot we can give her.
We've got to go home and get everything ready.
It's giving her something that nature didn't. We've certainly been able to restore her to a normal circulation, to normal oxygen levels.
Is anybody at the desk? Can we pass this cord to the desk? Give it to the girl. Okay. You saying bye? Thank you. See you again.
It's not going to be a complete cure, and she'll still have to face further surgery when she's older, because some of the tubes and conduits that we put in she'll grow out of. But that doesn't take away from the quality and length of life we can give her.
Go away. Another day.
We're pushing at the limits of what can be achieved technically in terms of surgery, and that can be hairy at times. But it's what drives us. And as long as we're not foolish enough to promise everything, then I think the amount of good we do is remarkable.